Good evening, everyone. Welcome to Grand Rounds, Cardiology Grand Rounds for October 3rd, 2022, as we continue our lecture series From Practice to Perfection. 1 week ago, we had the pleasure of hearing from Dr. Ambarish Pandey, who's the medical director of the Heart Failure with Preserved Ejection Fraction program at UT Southwestern. There was a nice overview of how to create a clinic for HFpEF. We reviewed guideline-directed medical therapies, and we also had a fairly robust discussion about fitness in heart failure patients who have preserved ejection fraction and how that impacts outcomes. Today, just for housekeeping, maintenance of certification credits and CMEs will not be offered for today's talk. I would like to introduce Dr. Partha Sengupta. As you know, he's our Division Chief at RWJMS, as well as our Chief of the Cardiovascular Service Line at the hospital. And today's lecture is Rare or Not So Rare Heart Failure with Preserved Ejection Fraction, Outside the Box or Thoughtful Restriction. And we'll have some Dr. Kebi from the Division of Cardiothoracic Surgery join us a little bit later as a panelist. So Partha, welcome and thank you for joining us and continuing. I'd like to say I know what you're going to talk about, but I was confused by your title and I look forward to you elucidating what you mean. So welcome.
Thank you very much, Anthony, for hosting us today, tonight. So what I'm going to promise today is something that everyone is going to learn a little bit more about heart failure preserved ejection fraction. And the opportunity of understanding this syndrome continues to grow. And after having about 15 years or 16 years of work that I've done in basic science, and I give talks about heart failure preserved ejection fraction, the reason I jumped up with the opportunity was because, number one, it was fresh in our memory with what Dr. Ambarish Pandey presented is an epidemic proportion, a problem of great significance. But I learned something recently which was related, and I thought I would share you, and something that really intrigued me because it is that requires you to put together not only just clinical cardiology imaging, invasive hemodynamics, and something that will be of interest. So fortunately for today's presentation, I have no conflicts of interest. And however, it's going to be a dynamic session. So please be prepared with your own either iPhones or smartphones, whatever you have, because there are going to be embedded questions that we would like to poll for making sure that we are keeping an impression or making an impression of whatever we are trying to say. And certainly this title is more of a riddle, but I'm sure you will soon understand that this is not really a riddle. It is actually going to be an interesting way to put forward to something that we experience every day, and that is heart failure preserved ejection fraction. And certainly it requires us to think out of the box because there are components which are very rare and not well understood. All right, so rare or not so rare. Let's start with our understanding of what are rare diseases. And unless and until we understand what the patterns are of rare diseases, we'll never recognize them. And it's interesting to know that there are myths that are carried around which influence our thinking. For example, French toast was not made in French, and it was in fact Joseph French who made it in the 17th century, and he forgot because of his grammatical error of putting an apostrophe, so it never became a French's toast. It's never was made in France. White chocolate is not a chocolate. It's doesn't have any cocoa product. It's all sugar, buttermilk, and fat. Danish pastries were not made in Denmark. It's a very interesting story. So it was the Denmark pastry workers went on a strike. So pastry workers from Vienna were brought in, and they used to make it actually in Austria. That's where it originated. They came and started making the pastries that they knew in Denmark, and it became famous from there onwards. And guinea pigs are not pigs. Neither they are from Guinea, and they are in fact rodents. So there are lots of myths about diseases, and we just carry them. We understand the cardiac pathophysiology, and we inherit our own biases on how we diagnose diseases. And today is about the same way of understanding a disease of heart failure, preserved ejection fraction. We'll revisit what we understand, hemodynamics of some rare disease, and how do we apply for a not so rare a problem. So to start off with, I'm going to go to social media, a case from social media that actually awakened my curiosity. Sanjeev Shah is a prolific researcher in heart failure, preserved ejection fraction, and he tweeted out, and this is a case from Twitter, and he talked about a patient, elderly woman, whom he saw obese with heart failure, preserved ejection fraction, a BNP not so high, and then he sent this image. And this is a image from the Twitter that I downloaded. So you have the echo image and the MRI image. You can see the LV, you can see the RV, and you see something funny going on with the septum. So take a look at that for a second, and then we'll get into our polling buttons. So make sure that you have your iPhone or your smartphone ready, because you can go into your image capture and serve a menu for you. And this is also invasive hemodynamics that he posted about the same patient. And this is all from Twitter, social media, okay? So we're learning from peers, our colleagues. So you see here, there is an LV tracing, and then there is an RV tracing. And it seems that the tracings, there are lines going up and down, and there are some words that are being mentioned there. Discordance, inspiration, discordance. And there are some characteristic findings here. So I'm going to want you to take a look at that. And now comes the point. So let's give it a try. What is the diagnosis? What is it? What is going around? Is it number one, not so rare, heart failure, preserved ejection fraction, rare phenotype of constrictive pericarditis, or it's a rare phenotype of restrictive cardiomyopathy? Maybe it's not so rare. Dr. Bakari told us about cardiac amyloidosis, and many patients with cardiac amyloidosis present with a restrictive cardiomyopathy. Maybe not so rare disease like lung disease causing carpal tunnel. So please go at your phone, take an impression. You'll be able to come to the website where these 4 choices will be there for you. And please pick up one. So I'm going to give you 30 seconds to, and I want to make people to commit. Okay, this is how we learn. So you need to commit to something. Your names will not come up. So please do not mind. So it is 4 choices. And pick up one that you like the most. There's also a web link probably available. If you don't have smartphones, you can use this web link and try to elect your choice. All right, so 10 seconds to go. Get ready. Let's see what it will come up with. I'm getting a text message. Maybe somebody wants to send me a personal. Only 8 people have voted. So I want people to go in, and so we're getting a 10, 12. That's great. So please pick out, throw off your inertia and vote We'll keep this on for a few seconds because I can tell you if you vote here, you will learn something because you're committing to some diagnosis. All right. So let's try to go ahead and see. 14 votes, so 50% mark. Let's take a poll now. Is that all right? Okay, let's go there. Okay, so we see constrictive pericarditis seems to be a winner, and there is a split going around between HFpEF and HFrEF. This is good because I think we will learn because there is a split. Everything is split here, so I think we'll learn here. Great. So yeah, so I'm going to focus upon pericardial disease and how does that cause heart failure, preserve ejection fraction. Now let's look into the pericardium. Okay, this is one of those organs that parts of the organs that we do not really care too much about unless you have a tamponade or pericarditis, and its contribution potentially to causing heart failure, preserve ejection fraction is something that is very interesting and curious. So we have a fibrous pericardium, then there you have a parietal pericardium, you have a pericardial cavity where the fluid collects in effusion, then you have the epicardium and myocardium, and then in between the parietal pericardium and the epicardium, you will have sometimes layers of tissue like fat that could get collected. Now, in constrictive pericarditis, what happens is your parietal and the visceral pericardium thickens, gets adhesed, and adherent can get calcified, and effusion fluid builds up. But independent of whatever be the mechanism through which pericardial diseases cause symptoms, the symptoms originate when filling is challenged. So there's an impediment to filling, and impediment to filling causes pressures to increase, left atrial and right atrial pressures to increase, and that goes back into the lung, and your lungs stiffen, and that's how you develop symptoms of shortness of breath or heart failure. So in constrictive pericarditis, which is the extreme form, it is quite it's quite rare. It is not commonly diagnosed. Probably most of the time it is missed, and the very fact that we don't see it often, I have a doubt that we keep missing it. But when it is diagnosed, you can treat it because you can relieve the enormous restraint that the layers are causing. And this, you can see here how the tissue bulges out and how much of restraint the pericardial layers cause around the heart. So we started the journey with right heart catheterization, left heart catheterization, and we looked at these are common measurements that are still practiced. We know about the prominent X and Y descents, equalization of the pressures in the cardiac, in the left and the right ventricle. And there were several other criteria which were introduced because it has been a difficult diagnosis, and the search for the right sets of criteria continued in cardiac invasive diagnosis. Liv Hadley, when she was visiting Mayo Clinic, found two very interesting phenomena. And what she found was that there were discordance and dissociation. So discordance was basically when you have the LV and the RV pressures moving in the opposite direction during inspiration and expiration, which is typically normally happens, but it gets exaggerated as the heart is restrained within the cardiac, in the constrictive pericarditis. And the second feature which was shown was that the intracavitary pressure of the left ventricle was dissociated from the intrapleural cavity. So when you take an inspiration, the pressure would fall more in the lungs, in the wedge, yet it will not be transmitted inwards into the LV cavity where the pressure will stay elevated. So there was a dissociation between the intrapericardial and outside the pericardial pressure during the diastole. So this was what was then subsequently used and refined and is used in the cath lab. You look at the pressure tracings inside the LV and the RV, and you look for this dissociations in the LV and RV during the respiratory cycles. And that's how you diagnose constrictive pericarditis. You can use non-invasive imaging in which you can see this interdependence of the ventricles. So the septum, because the amount of the volume inside the pericardium is checked, so the two ventricles compete with each other for the volume. So during inspiration, when the right ventricle fills in, the septum moves towards the left ventricle and vice versa during expiration. So this movement of the septum during the cardiac cycle is signifying that there is competition between the right ventricle and the left ventricle for volume. In addition to that, because the LA and the RA pressures are high, when the blood comes in, it creates a transient vibration of the septum. So you get like this shuddering of the septum that is also appreciated during early diastole. So these were the features were first described, and subsequently with further description of development of Doppler technology, the respirophasic variation became very well defined. This was, of course, work that was done in Mayo Clinic, where the respiratory Doppler shifts that happen in the transmitral and the transtricuspid and also in the hepatic vein and the SVC can be used to look into this exaggerated dependence of the two ventricle causing large shifts of the velocity during the respiratory cycle. And that's how you try to diagnose constrictive pericarditis. And this was popularized again by Liv Hatley. And you can see here the movements in the transmitral flow, which are varying. So this is the beginning of the inspiration, and this is the beginning of the expiration. You can see the inspiratory mitral flow is low and it's jumping up during expiration, the E. So this change is what is used for diagnosing an exaggerated respiratory transmitral flow velocity, or maybe it in hepatic vein Doppler, which is very, very specific. If you see this flow pattern, so normally the movement of the blood during inspiration should happen away from the transducer. So it's moving, being sucked from the IVC and the hepatic veins towards the right atrium and right ventricle. So there is a forward flow, filling flow in early and late diastole. But when the expiration starts and the septum is bulging into the right ventricle cannot accommodate any further flow. So in fact, the flow starts moving backwards. So this is reversal of the flow, hepatic vein flow reversal, and this diastolic reversal, which marked respirophasic changes, is very rarely seen in any other condition, and it's a very specific sign of constrictive pericarditis. We have started diagnosing pericardial restraint in RWJ with a little bit different flavor. So this is, I think, one of the first recording that Dr. Megan Nehas and myself, when we were in consult services, made of the same findings, what you see of exaggerated interventricular interdependence using a small iPhone. So this is the butterfly ultrasound technique or using the pulse wave Doppler. This is in a ER in a patient who has got elevated neck veins, or putting it even the Doppler in the hepatic veins, and you could record that. So yes, we can bring some of these observations to the bedside and help understanding that this is a challenged ventricle. There is a restraint happening, and there is exaggerated interventricular interdependence. And this is a problem. And in fact, if you see this interventricular interdependence in which the septum is competing between the two chambers, this is a bad sign in general for hemodynamics. That means that there is a lot of pressure variations happening, and the ventricles are working in a very restrained environment. They're not able to relax well. It can also happen in other conditions like pulmonary hypertension, RV failure, and is an important sign to be seen. In chronic calcific pericarditis, there's an additional problem that happens sometimes, is that you develop atrial fibrillation, and sometimes the pressures become so high that respiratory variations may not happen. And it's you can see the square root sign and the checking that is happening in this patient who has got clear calcified pericardium, and a very classic hemodynamics of constrictive pericarditis. And yet you don't see a lot of respiratory variation, or if respiratory variations are happening because there is atrial fibrillation, it's very difficult to differentiate. And in that situation, you can use myocardial mechanics and see if the left ventricle is relaxing normally in terms of its speed of relaxation that is measured by ultrasound, then you know that it's a normal myocardium that is relaxing well. And you can eliminate myocardial disorders as a cause of elevated filling pressure or heart failure with preserved ejection fraction. But this is where my journey actually started. Believe it or not, in 2004, I came to American Society of Echo and got a time that I spent with Dr. Pandian and developed some work, went back, and then when I was presenting, then Dr. Kanderia from Mayo Clinic picked me up at a conference and offered me to come to Mayo Clinic. And all this work I did along with my mentor in New Delhi, Dr. Mohan. This was subsequently published. But then there was this excitement on looking at deformation of the myocardium that was becoming very, very interesting. And this is in Mount Sinai. Dr. Sharma has called me for doing a pericardial centesis on a patient. And this is a patient on the table, and fluid has to be drained out. And what happens? Of course, the echo has been done elsewhere, and the patient has been brought to the table. And I see this abnormal septal motion. You can see that abnormal septal motion. There's a lot of fluid collected. And when I look on the table, these are my own images. I see the IVCs dilated, filling pressures are high. He asked me the question, actually, what is the LV function like? Can I just go ahead and do, just help me through? And the speed of the myocardial relaxation is hypernormal. And actually, I said that pull this patient off the table. This is not a patient of pericardiocentesis. This patient has constricted pericarditis, and what you're seeing is actually a lot of effusion, pleural effusion. And they looked at me aghast, but the ventricle, how you know for sure? And then we went on to do some strain on the table and showed them that, look, the ventricle is completely normal. This is not a pericardial effusion. This is all pleural effusion, and the patient got off the table. And then another day, this is, of course, then the CT was done, and that the patient, of course, has a very large pleural effusion. This is not, and the patient has constrictive pericarditis, and the ventricular function and the longitudinal function is completely normal. It's a carpet of red. It's a very healthy longitudinal function of the myocardium. On the other hand, this patient was another patient brought to the table for pericardial effusion. These are all, both the patients are from Mount Sinai, referred from outside, comes on the table, and again I look at the heart. This is not This is not pericardial effusion. This is pleural effusion. But now what's happening with the ventricle? It looks like the muscle is moving, and it's difficult to sometimes tell whether the pericardium is thickened or not. You can see the pericardium. There's a suggestion that this is moving. And then you put again the other things into equation. There's a restrictive filling pattern. The pressures are high, but the myocardial velocity are very reduced. So this is a challenged myocardium. And when you put the myocardial function analysis, you see a cherry on the top appearance. And this is a typical appearance that you get on what Dr. Bakari suggested of an infiltrative cardiomyopathy like amyloidosis. You can see it in other places also, but this is typically in a patient, unless proven otherwise, this is of a restrictive cardiomyopathy. So again, this patient was pulled out of the table. But then I took all of these findings, and then this was the paper of disparate patterns of ventricular mechanics in restrictive and constrictive pericarditis that was published subsequently. And not only in ultrasound, because of the multimodality imaging, Dr. Amaki, who was visiting from Japan as a cardiology fellow, published this work when he was at Mount Sinai, in which further additional insights from CT and CMR is very helpful. You can see the inflammation. Whenever there is inflammation, you can, in fact, give them therapy with steroids and non-steroidal anti-inflammatory agents, and you can actually have some of this inflammation taken away, and there is a reversible constriction that happens in a lot number of patients, and where you don't have to do pericardial resection. But obviously, this patient obviously didn't respond, and there was a thick rind of pericardium that was removed. But and all the myocardial mechanics that we showed in ultrasound was also doable on feature tracking on magnetic resonance imaging, as was presented in the study. So multimodality imaging was also developed and expanded our ability to diagnose constrictive pericarditis. Yet it is a difficult disorder to diagnose, and the very fact that we don't see it often means that we're missing it. So if you see any of this clustering of abnormalities, think about constriction. And then, of course, there are new machine learning techniques and all. I've been using some of this work that has been published. So let's come back to now the poll. Let us see what you think about this case that Dr. Sanjeev Shah presented. What is the diagnosis now? And let's go back into the poll and let's see what is the situation in this case. So the poll is going around. I'm hoping that people are going to go ahead and try to now take a assessment based upon what we presented. So now we will know what is interventricular dependence, what is dissociation of pressures, so on and so forth. Okay, so Dr. Yanmala is going to give me signal sometime. Currently only 6 votes, so we need some more. Come on, come on. So what is the diagnosis? Please vote. And there is a reason, because if you don't vote now, you will not alone, I can tell you. And this is something, 8 votes, a few more. People think that this is easy, right? And the reason we may think that this is easy, but it's a difficult diagnosis. But I want, the link is posted in the chat as well. So 10, 4 more. Let's do at least 50% people. I want people to just make an effort to vote. All right, 30 seconds more, and then we will take the poll. All right, so maybe some people can poll while the polls are on. Okay, very good. Very good. And that's the trap. So I've now convinced you that what Dr. Sanjeev Shah showed you is a rare phenotype of constrictive pericarditis, and it is a rare disease, and everybody is convinced we showed you constrictive pericarditis. If it was so simple, I would not have presented, I would not have jumped to give this talk, okay? The plot is going to become interesting here onwards. In fact, this patient that Dr. Sanjeev Shah presented has severe pericardial and epicardial fat over the right ventricle, okay? And what was happening is that this pericardial fat and epicardial fat, once it starts growing inside the pericardial cavity, starts competing with the right ventricle and the left ventricle for space. And now imagine the patient is obese, obviously, and this competition causes a problem of the working of the heart. And so today what we're going to learn is an emerging paradigm in how infiltration with fat inside the pericardium is becoming a major area of research and significance. And if we don't keep our eyes and ears open and don't think about doing, you're probably seeing all of these patients all the time and doing all the things that you will think you want to do, but someone else is going to take away the credit for the discoveries. So, all right, so let's talk a little bit more, because now it's more important and interesting. We discussed about constrictive pericarditis and how the pericardial restraint around the heart causes elevation of filling pressure. So let's understand our physiology a little bit more. So you have the pressure inside the left ventricle, the diastolic pressure. As the chamber is expanding, it faces two resistance. One is the resistance that is going to come from the tissue, the myocardial tissue, or what will be the pressure of the transmural tissue. So this is the transmural pressure. So it will give a pressure and it will try to counter this pressure that is coming from inwards as it's trying to expand the chamber. And the second layer of pressure that comes out is from the pericardium, the external. So these two pressure get balanced with the intracardiac pressure during any cardiac cycle, filling cycle phase. Now, this pericardial pressure is very closely approximated with right atrial pressure. And this is work from John Tyberg, when they showed that the right atrial filling pressure, mean pressure, is very closely related to this pericardial pressure. And how did they do it? They actually implanted pressure manometers in the pericardium, in space, in the muscle, inside the cavity, and they made all this correlation. So from this, therefore, you can understand this, that this pressure measured here has to be equal to the pressure of the myocardium and the pressure that is coming from the pericardium. They have to both equilibrate for a given volume. Now let's see what happens in a closed pericardium. So you have the left heart volume. You can give fluids and you can increase the volume. And you have the left heart pressure. Now, typically, both go up. As the volume increases, there is, because of this resistance from the myocardium and from the pericardium, the pressure will go up inside and it will stay equilibrated. But let's look into what happens when you change the right-sided volume. This is at 0 degrees, 0 ml of volume on the right ventricle. This is at 25 and this is 50 volume. So as the right ventricle volume increases, the septum keeps on pushing onto the left ventricle and causes the pressure on the left side to further increase. So this is the effect of one chamber on the other. So this becomes very interesting. So in a closed pericardium, the two ventricles interact with each other, or they are forced to interact with each other. And therefore, as the right ventricular volume starts increasing, it competes with the intrapericardial space, and therefore, for the relationship between the left heart volume and left heart pressure increases more precipitously. Very important. But what happens when you have a pericardiectomy done or a open pericardium? Now the two ventricles are not connected to each other because they're not competing for a space inside the pericardium. This relationship is gone. So now the right ventricle and the left ventricle can just expand the way they want, and the relationship with the pressure of the left ventricle and the left ventricular volume, they are just coincidental and no relationship to right ventricle. So this is the effect of pericardium. What does it do? A normal pericardium actually prevents excessive dilatation. Otherwise, when you're running a marathon or somebody else, in fact, you should see the RV of a marathon is huge, and there's a lot of volume that comes in. So there's large amount of volume shifts can happen. So the normal pericardium does not allow excessive, unreasonable expansion of the ventricular chamber, which will be, again, a big problem because the stress-strain relationship will really hamper the myocardial function. But imagine what would happen if now, in place of right ventricle and the left ventricle and the myocardium, other things starts coming in, and that's the fat. Now, if the fat starts building inside the cavity, imagine what could happen. It will become another competitive agent for the space. And since it will start taking volume, now the right ventricle and the left ventricle will start becoming more dependent. So if the right ventricle fills up, the septum will move, and so on and so forth. And that's what is starting to happen as a concept. So in the so-called heart failure preserved ejection fraction, there's a large percent of patients who are obese. And what happens in these people, the fat starts creeping inside the pericardial space and starts competing the wall inside the pericardial volume. And a lot of wonderful work that has come from Mayo Clinic, Barry Borologs and colleagues started looking into it somewhere around 2017-18. So it's a very, very recent concept, but very, very exciting for the field. What you see here is the septum becoming flat in people with obese and heart failure preserved ejection fraction. And I can tell you, as non-invasive cardiologists, as fellows, as myself, we have seen this all the time. We see this and we think, oh, maybe it's because of pulmonale or pulmonary hypertension, or maybe the patient got sleep apnea. But we never think about whether it is because of the challenge that is being imposed by a competing space issue inside the pericardium. And what the investigators have started looking into is the eccentricity. So if the septum moves inward towards the LV, it no longer becomes circular. Your relationship in terms of anteroposterior versus a lateral radius is altered, and this is called as an eccentricity index when it exceeds 1. They started observing that more frequently in obese heart failure with preserved ejection fraction population. Not only that, you can observe that using echocardiogram. In parasternal view, you can measure the fat layer. And often I've seen people making a mistake of pericardial effusion. This is the epicardial fat layer that can be measured. And this is when this exceeds more than 9 millimeter that's where they have started seeing that it starts competing for the intracardiac space. And in this second work that was again coming from Barry Borlaug's and colleague, they showed that in people who have this increased epicardial adipose tissue, there is higher right atrial pressure, pulmonary wedge pressure, and mean arterial pressures. So there is a component that is related to how the epicardial fat starts accumulating. More and more work. This is work from Europe that did the same thing. Now they had actually invasive monitoring of the filling pressure, and they had also the CT scan pericardial fat volume that was calculated. In these phenotypes, there were close to about 169 patients that were followed up over a period. And what they found that patients with higher epicardial fat volume over 100 ml per meter square had higher incidences of death and heart failure hospitalization over time. So this again contributed to the prognostic signature of the data that has started coming in heart failure with preserved ejection fraction. So now what we have seen up till now is you can diagnose it on echo. There is eccentricity, and there are features of septal flattening and increased interventricular interdependence. But also not only that signal is associated with invasive hemodynamics of elevated filling pressure and also with outcomes of heart failure. One step more, Barry Borlaug and colleagues and Sam Asirvatham, they designed an experimental model, and they created a experimental model of heart failure with preserved ejection fraction, in which the guinea pigs' renal arteries were occluded with coils, and they developed hypertension, hypertrophy, and that's a experimental model of heart failure with preserved ejection fraction. And in that model of developed heart failure in guinea pigs, or I think it was not guinea pigs, it was pigs, they then performed pericardiotomy. So they devised a wire-based pericardiotomy, a very interesting design, and I think soon maybe they may want to test that in humans. But is in this early phase, they created pericardiotomy, and what they showed in those in the dogs and the pig models, that not only there was a reduction in the pressure, but it was sustained in even the pigs who had developed heart failure. So you can see the volume increasing and the pressure reducing. Now imagine the implications of something like this in our heart failure population. I'm not suggesting that this needs to be done, but imagine where the field is moving. And this is just in the last 3-4 years. And this is the garden variety heart failure with preserved ejection fraction of obese type, where this new physiology of increased interventricular interaction and the contribution of the pericardium to it is becoming very exciting. Now, not only in pigs, then they have gone ahead and done in human. And this was a research letter in circulation in which in patients who were undergoing CABG and aortic valve replacement, what they did was in the OR, after the chest walls were opened up in humans, they did fluid infusion before and after pericardiotomy, and they also did leg raising and all kinds of exercises. We need to be more creative in thinking, why is it only in Mayo Clinic this can happen anywhere? So imagine all of these patients we can design nice studies. And what they showed that once the pericardium was opened up, the wedge pressure actually fell down. And this was sustained. And in fact, when they did the leg raise in few of the human patients, they were able to show the same physiology. So this is becoming interesting, that the heart failure with preserved ejection fraction, what we think about the myocardium only relaxing, particularly in obese variant, and if you see a lot of epicardial adiposity, there may be a lot of pericardial restraint, something that happens in constrictive pericarditis, maybe a physiology that is happening in this patients. So it's not constrictive pericarditis. In fact, this patient that Sanjeev Shah reported in Twitter was a garden variety heart failure with preserved ejection fraction, who had an abnormal septal motion, increased interventricular interdependence, and a hemodynamic catheterization feature that was absolutely like constrictive pericarditis. So what I want to say is we all see a lot of heart failure. We see a lot of obese patients who come off shortness of breath and swelling over the feet. Maybe this is one of the mechanisms you need to look for. Maybe in your echoes and your CT scan, we need to be more vigilant. And I learned this very recently, and that's why I got fascinated. And when we were presenting last week our work on heart failure preserved ejection fraction, I thought it's very stimulating to talk about this, because if you understand this physiology, you understand 50% of cardiology. If you understand constriction, restriction, echo, and hemodynamics on cath lab, you know a lot of cardiology. And this is very important, therefore, to practice. But this is just not in diagnosing heart failure. In electrophysiology, the fat around the atrium, okay, is a rich source of inflammation. And there is a lot of different work in research literature that is happening of how this fat and the inflammation from this fat affects coronary atherosclerosis, affects the development of atrial fibrillation. And in fact, I was thinking, and this may be something very interesting, if the pericardial space is constant and it's not easily expandable, imagine what happens when the atrias are expanding in AFib and becoming gigantic. They will also push the ventricles to compete with each other because the space is limited. So we hardly know much about how this physiology is evolving and how all these features are working. So this is a untapped area where we need to be very vigilant and seeing where the literature is evolving. But in addition, in our academic settings, this is a rich area for us to develop some hypothesis in retrospective or prospective way, work with our multidisciplinary settings of cardiac surgeons, invasive labs, non-invasive labs, preventive arms, and see how this can work for all of us. We know that constrictive pericarditis is a rare cause of heart failure, preserved ejection fraction, but there is a mounting evidence that pericardial restraint due to dilated chambers, fat infiltration, may be contributing to elevation of left-sided pressures. Well, at this moment, I think if you see a heart failure patient who is obese and you diagnose all of that, I wouldn't recommend you doing a pericardiectomy, because maybe first we need to think about weight management, weight loss, bariatric surgery, going them through GLP-1 receptor antagonists, because they can be a lot of volume reduction. And simply reducing the volume and the challenge that the right ventricle faces can be very useful in reducing this interventricular interdependence. And also, of course, GLP-1 receptor antagonists can cause weight loss. So all of these features are investigational. We need to be open to looking into this area. And maybe in future, we need to think about pericardiotomy, and in our discussion, maybe if there is time, and there will be some time, maybe we should talk about what do the surgical people think about stripping off the extra fat that is around the heart. I know that I looked into the case, there are case reports of extra fat or extreme fat collected around the heart have been resected and thrown off, but I don't know what is the role of removal of the fat around the heart, because it seems that there is a lot of inflammation that is caused by this fat. So this is, again, more food for thought. But if we don't think about our opportunities, and these are all, every day you're seeing these patients. You're seeing electrophysiology, AFib every day. You're seeing heart failure every day. You're seeing the interactions of all of this happening in your patients every day. We need to be open to discovery, because this is where the opportunity is lying in our environment to create some newer directions to our thinking. So I invite more consideration But I thought, in my humble opinion, for the last 14, 15, I give talks at the ASC, I give talks about in the board meetings about diagnosing constrictive pericarditis, but this physiology really was refreshing to me to understand, and therefore I wanted to share this. And when Andrea told that was an opportunity of 1 week that there was no presenters, and I jumped upon this opportunity to present you with some of this newer information. Thank you very much.
So thanks, Partha. Very provocative discussion. You know, in 2021, there was a lead article in JACC that got a lot of play in the popular press, and that was pericardial fat and the risk of heart failure. It was recognized that with increased pericardial fat, there was an increased risk of heart failure as measured by volumetric analysis using CT. And actually, although women had less pericardial fat than men, those that did have pericardial fat were at higher risk for developing heart failure. So the question is that I would ask, and we're going to bring Dr. Takebe in from some of his insights from the surgical perspective, can pericardial fat be used as a prognostic tool for heart failure? And what do we know about pericardial fat volume pre and post bariatric surgery, similar to how we use coronary calcium as a surrogate marker for coronary heart disease?
Is Dr. Takebe, I think he has joined.
Manabu, are you there?
Yes, I'm here.
Good. So I think that from the medical standpoint, we're very curious about using pericardial fat as a surrogate marker for the development of heart failure. From the surgical side, you operate and do bypass on many patients with preserved ejection fraction, some of which are obese. What do you see intraoperatively? And Partha had posed a question, what can be done about that pericardial fat and that adipose tissue?
So, it was very interesting lecture by Dr. Sengupta. Can you hear me? I'm sorry.
Yes.
So I practiced in Florida before coming to RWJ, and lots of patients are actually very obese, like BMI 45 to 50. Then, what we found there was, we see more, when we open the pericardium, heart just pop out, So basically, yes, I'm not talking about pericardial, but even epicardial fat on the heart is actually affecting diastolic dysfunction, I assume, because it looks super tight. And then talking about but I really don't see much experience to see relationship between epicardial fat and the diastolic dysfunction or coronary artery disease. But often, whenever we operate on CABG patients, the superficial, vessels are more likely affected by the to the coronary artery disease than the where whatever vessel in the muscle or whatever in the vessel in actually fat. So I it's the two different things is very confusing for the coronary artery disease. I actually may think whoever covered by tissue is actually helpful to prevent the coronary artery disease. On the other hand, for the diastolic dysfunction, I guess for obese, especially obese patients who have the RV dysfunction, concentric or diastolic dysfunction, we see some benefit to open the pericardium. Oftentimes we leave the pericardium open just because heart is very kind of pressurized by pericardium.
Yeah, so Manabu, I just wanted to so there's work going around on pericoronary adipose tissue, and what they're finding is that actually it's pretty atherogenic. In fact, it's opposite of what you're proposing. It's there is more and more work coming now that peri-adipose tissue, and they're using something called as radiomics to look into that, and they can actually identify how that is related to the development of atherosclerosis. Maybe we can look into that together. But my question to you is, how easy? So you're saying that when, in your opinion, that it is very tense, and when you split it, it just pops out in many of these obese patients?
Yes, I mean some, not all, but
Not
some
all.
patients like just heart is pop out from the pericardium.
Wow. And what do you do in that situation? So obviously you're not closing the pericardial layers, are you?
No, we don't. So there's some studies to see like, whether, we should close the pericardium or not. And the good, bright side to close the pericardium is actually decrease the, some studies show some decrease of the atrial fibrillation. I don't know why, but many, some studies shows like, after the surgery, patient experience diastolic dysfunction when we close the pericardium. So, it's a controversy, depends on the study, what they're looking. But I see whenever we operate obese patients, especially, diastolic dysfunction, obese patient, we tend to leave it open.
And how difficult, suppose there is excessive fat collected, you see, how difficult is it to remove that, or you don't care?
Many times we don't care, like, usually it's not that a lot to, push your heart, but yes, there's some cases we see too much, fat tissue, and sometimes we take it out.
You do take it out.
Yes.
And I see. Okay. But let's say I'm thinking in terms of doing a study, because all these people, let's say if there's an obese patient going in, maybe we could do a protocol to see before and after. What I'm trying to say that in maybe a randomized fashion. Of course, it has to be a IRB approved. But if it's not very difficult or dangerous to take away the fat, maybe just remove some of the extra fat, maybe they will have a better recovery. Particularly in some, I know the elderly woman with valvular heart diseases like aortic stenosis, they have little difficult time recovering because of their stiff ventricles, right? I don't know. In some forms of some places, maybe it may be helpful. Do you see of any study design that we could do?
Yeah,
So maybe we need to explore
patient selection, or what we are looking is very critical, I think, because I'll say many patients not gonna have any effect from by taking out the pericardial fat, but there should be some patient beneficial from the those procedure for sure. So we kind of need to be careful about like patient selection to see, because otherwise we need lots of patients volume to see. I would say like high BMI patients with the diastolic dysfunction patients, and then then we can certainly try to do it. We can even do minimally invasive stuff.
Partha, I think another aspect to this is the forgotten ventricle, the right ventricle. One of the MESA sub-studies looked at RV function with pericardial fat, which we know is not circumferential. And with pericardial fat, it does change the morphology, smaller end diastolic volumes. It impacts end systolic volumes and stroke volumes. Conceivably, if you had patients with clinical right heart failure who were going in for a procedure and had a body mass index of, let's say, greater than 40, it would be interested to look at right ventricular function pre and post surgery if RV adipose tissue or surrounding tissue was removed. So I think it's important also to think about the right ventricle, which may be at a higher risk for having fat having an impact on its performance.
Yeah, and while we are also thinking about the RV and the performance, I also feel like we probably need to be more aggressive about bariatric surgeries and ways to move towards weight reduction therapies, particularly people who are developing early signs of diastolic dysfunction, because once they develop heart failure, it's too difficult to treat them. But another idea could be is to take patients with known heart failure with normal EF ejection fraction and who are obese, to naturally aggressively recommend them bariatric surgery, and it'll be interesting with the weight loss of how much of the heart failure goes away, and to statistically look into that, all of that, right? And that would be a service, because I think the whole idea of your previous question of how much does the intrapericardial fat volume itself, visceral fat, will go down, I do not know. Maybe I'll have to look into the literature, but maybe we should be more aggressive about bariatric surgery, and we do not do that as yet. Maybe it should be connected to our heart failure clinics and in a multidisciplinary settings.
Yeah, we have a very prolific surgery group for bariatric surgery led by Dr. Sadek. I can tell you in my practice, I have patients with multiple comorbidities. They tend to be younger, and we're using bariatric surgery as an effective means to control the cardiometabolic syndrome. I think it would be very interesting if we can profile these patients and get a volumetric assessment before and after bariatric surgery, and again, try to figure out what it could potentially mean. So we may use bariatric surgery more aggressively in this patient population, not just in those with heart failure.
Yeah, and so basically, I feel like if we even go retrospectively to the data charts or people, I mean, in bariatric surgery, they typically have, everybody gets an echocardiogram done. Many times they come for a clearance and things like that. I've seen that happen very frequently. So maybe we can look into and create a registry and see if there is an effect, and do maybe bring them back for a follow-up to see how they're, you can definitely measure the RV free wall epicardial fat thickness and see how much that regresses. And these are very small studies and easily doable ones that can be designed.
Well, good. I like to thank Dr. Sengupta for really a challenging case. I think he kind of threw me off when he didn't mention atrial fibrillation in this patient, so I wasn't thinking about pericardial fat. But nonetheless, great case. Dr. Kebe, who's a valuable member of our cardiothoracic surgical team here, we thank you for his input. And most of all, we thank you, our attendees, and we will see you again for our next grand round shortly. Take care, everyone. Good night.
No.